We are doing overdose awareness and prevention tips. So I welcome y'all's comments, questions. I want y'all to participate. I don't want to just read the slides. And some of this stuff, I know not everybody's going to agree with or maybe have some personal feelings about it. If y'all want to talk about it, now would be the time to do it and kind of process how we're all feeling and how we would deliver this to the clients. So I think about presenting this information as I would present it to a client. That's how I do this training. Y'all can think about it however you want to apply it to your own life. This training right here is how I actually do my overdose awareness with the men's unit. So all the information y'all are getting, they get the exact same thing. We have the exact same conversations that I would have with y'all. Okay. So we're going to go over opioid overdose and then how to respond to that, naloxone stimulant overdose, responding to that, and then harm reduction. So, does everybody here know what overdose is? The basic term, what would you say? Doing too much. What can you overdose on, technically? Heroin, alcohol, weed. Mm-hmm. You can technically overdose on any substance. They're just how it affects you is going to be different. Do y'all all know what the 3 categories are that would require, medical usually? Like what 3 categories do you think if you had an overdose you would need to seek immediate medical help? Alcohol. Yeah, basically the same stuff that requires detox is the ones that put you at the highest risk, that you're going to need help. If you overdose on cocaine or methamphetamine or something, there are things that you can do to help calm the situation down that wouldn't necessarily need medical assistance. So we'll go over some of those differences a little bit later. So basically, overdose happens when a toxic amount of a drug or combination of drugs overwhelms the body. People can overdose on a lot of things, including alcohol, Tylenol, opioids, or a mixture of drugs. This says about 43,000 Americans die from overdose every year. I think the number has increased. I know in 2013 they said that about 800 deaths had been assigned to overdose alone, but they weren't actually considering deaths of people who overdose from like hydrocodone or something. They weren't thinking about all the prescription pills included in that. So the number is going to be a lot higher than that. Just 2 more definitions I want to go over. Does everybody know what tolerance is? Okay. What is tolerance? Okay. So what happens to clients' tolerance when they come here? It goes down because they're hopefully not using while they're here. Okay. Do y'all know what a half-life is? Right. So it refers to the time it takes for a drug to drop to half the strength of its original dose. Some drugs have a long half-life and some don't. So the example that they give is benzos. Valium has about a 24-hour half-life. So it's basically saying if I take 20 milligrams of Valium today, tomorrow, how much Valium am I going to have in my system? 10. So it's good to help and the clients, you'd be surprised how many of them don't know this. When you wake up the next day, you actually still have the substance in. So if I decide to take another Valium when I wake up, I now have 30 milligrams instead of the 20 that of the pill that I took. Opioid overdose occurs when the level of opioids or combination of opioids and other drugs in the body render a person unresponsive to stimulation or cause their breathing to become inadequate. This happens because opioids fit into the same receptors in the brain that signal the body to breathe. If someone cannot breathe or is not breathing enough, oxygen levels in the blood decrease, causing the lips and fingers to turn blue. So basically the thing to remember is, and I forgot to put the picture up here of it, is you can imagine a receptor and the opioids will fit directly on top of that, stopping your breathing. So that's the main thing that when we talk about how to respond to an opioid overdose, one of the main things they want you to do is breathe for the client because they need oxygen. So within 3 to 5 minutes without oxygen, brain damage starts to occur, soon followed by death. And then some opioids include heroin, morphine, codeine, methadone, oxycodone, hydrocodone, and hydromorphine. All right. So what do y'all think about when you hear somebody overdosing from opioids? What do you think that looks like? Nodding off? What other symptoms do you think? Okay. Throwing up. Did somebody say sleep? Sleeping? Yes. What else goes with sleeping? Gurgling, snoring, maybe. Those are not good signs. Skin looks pale or blue. Body is limp. No response. With opioid overdose, I think it's kind of difficult to identify. You've got to kind of assess the situation to see if they're actually overdosing, because somebody nodding off and, just not really, I guess their speech is slow and stuff like that, that could just mean that they're high, because that's the same symptom as that. It's the other stuff that you need to be more concerned about. If their fingers are turning blue or their lips are blue, they're unconscious on the ground, those are good signs that they're overdosing. And then just to point out, most overdoses are more likely to occur an hour or two after use. I know in the movies they like to portray that you take a shot of heroin and then you're immediately overdosing. That's not always the case. Not saying that it can't happen sooner with some people, but a lot of the time it's an hour or two later that it'll kick in. All right. So, can y'all see that, or is that too small? Too small? Okay. All right, so priority groups and risk factors for opioid overdose. These are the people that are higher risk when it comes to just opioids. Recent medical care for opioid poisoning, intoxication, or overdose. History of heroin or opioid use. High-dose opioid prescriptions. Recent release from jail or prison or detox or rehab. If they're taking methadone or Suboxone. If they live in an area that it's not easily accessible to, say, go to the hospital or something. And any opioid prescription and known or suspected medical issues, alcohol use, benzodiazepine use, or antidepressant prescriptions. Recently, who of y'all heard, I guess, what substance has caused more overdoses? Heroin or prescription pills? Why do y'all think that is? It's easily accessed. It's legal. I think what we talked about earlier about half-lives is people not understanding how the pills actually work in the body, so they're kind of putting more in. Right. Or mixing the two. All right, so responding to an opioid overdose. The first thing that you're going to do is stimulation. Have y'all ever heard of the sternal rub? Have you ever done the sternal rub? Okay. Have you? Does it hurt? You felt it? Okay. So the whole point of that is if you're trying to see if somebody's aware and present and they're not necessarily responding to you saying, and I always need to make this clear to the clients, I don't recommend punching somebody in the face or slapping somebody. If they're not awake or coherent, that's not going to wake them up. All right. But the sternal rub, if you push really hard down right here, you'll see that it hurts. So if somebody was actually applying that pressure, trying to wake you up, if you're able to, it's going to wake you up.
I've seen someone do it, like, a passenger, someone who makes it falling out and working on it. I thought it was stimulating the heart. It's just
Stimulating them. Okay, so the second thing that we're going to want to do is call for help. When you call 911, be specific about the symptoms. So basically, whatever it is that is being seen right in front of you is what you want to tell them. This man is unconscious on the floor. His lips are blue. Doesn't sound like he's breathing. Just stick with those basic things. Don't go into detail about your opinions or if you think that they're overdosing or, that's not the time to be revealing that kind of information. And then if you have to leave the person alone, place them in the recovery position. Have y'all seen this before? I'm sure y'all can't see that. So basically, it's a person, you lay the person on their side, their head's going to rest on their arm so that their, mouth is pointing downward. And usually you pick a leg up to keep them balanced, but it's so the person doesn't choke on their vomit if that's happening or, kind of open the airway.
The leg is for that reason, or the arm behind the ears?
The arm behind the ears to keep their head tilted forward. The leg is to keep them secure because if they move around and, their leg's not down, they roll back over onto their back. Number 3, they want you to ventilate while waiting for the paramedics to arrive. So plug the nose, tilt the head back, and give 1 breath for every 5 seconds. Again, if the person's already breathing, don't perform this because they're there and they're with you.
I don't know how to do that if they do vomiting. So I was just thinking, how would you
Well,
we don't always have to vomit. I don't know.
I mean,
You get a rag and you wipe it away.
thinking about it right now, I would say no. But when you're in the moment, you're not going to care. But say if somebody were overdosing here and we had to come to the rescue, we have stuff that we can use. I don't want to say that either, but I'm going to say, how often are you going to be outside of work around a bunch of people that could possibly overdose? So hopefully not. Yeah.
It should be like a given, right?
Yeah. But I would take your shirt, wipe their mouth out, because the alternative could be death. Because again, like we said, the receptors fit on the breathing. The opioids fit on the receptors for breathing. So the one thing they need is oxygen. They need to breathe. So this is one of the most important steps. And then the 4th one after that is to administer naloxone if we have some or if you have some on you. If you don't, you're just going to have to wait for the paramedics to arrive and continue performing the breathing if they're not breathing. So how to use naloxone, and we'll go into that after this slide, is you're going to inject 1 cc into the large muscle of their upper arm or thigh. You can repeat the process in 3 to 5 minutes. But you cannot go over 2 shots in a,
I don't think so. All right.
Last time I did the training, I searched the building trying to find, because I swear I was told that we had them because we got the trainers, but I wasn't able to find them anywhere. But we were able to have them, so I don't know what we need to do to get them in here.
Our laws have changed to make it more of it.
Yeah, and we're going to go over that too. Yeah. So after you administer naloxone, basically all you can do is evaluate and support. Just sit there with them, make sure they're okay, give them anything that they need. Hopefully they'll be awake by then. And then once the EMS arrives, that's when you want to tell them exactly what happened, what you think they took, how much naloxone you administered. If you had to perform breathing, that would be the time to tell them everything. So naloxone or Narcan reverses an opiate overdose by blocking the opioid receptors in the brain. It wakes a person up who's overdosing in 3 to 5 minutes and is active for about 30 to 90 minutes, at which time the effective opioids can return. So one of the main things to understand about the drug when you administer it is, since it reverses the effects, what does it do to that person pretty immediately? If it works, it'll wake them up. It puts them into withdrawal. Okay? So to understand this drug, it is just there to reverse the overdose, which means that you still have whatever you used in your system. It doesn't clean your system out. It just stops you from, being at a high risk. So you'll immediately kick into withdrawal. So one of the things that they like us to share with the clients is you can't continue using after that. Because the likelihood of you hitting another overdose will be like 95%. Okay. So, this has no other effects, and you cannot get high on it. You cannot use it for any other substance, alcohol, Xanax, cocaine. It doesn't matter. It won't work. You can't get high. You can't abuse it. It is strictly for opioid overdose, which I think is pretty cool because how often do you find stuff like that? All right. So, yes, the last paragraph is just talking about the withdrawal symptoms. And usually when a client hits withdrawal, especially as immediate as it would be, their first reaction will probably be, I want to make this go away. And if you say we did actually administer naloxone or we're sharing this information with the clients, the chances of the EMT being there at that exact moment are probably slim. So there's usually drugs around them at that time. So you want to make sure to share with them that using will put them at an even higher risk. All right, so in September 2015, we got Senate Bill 1462, which made a lot of changes in regards to naloxone. It permits any person otherwise authorized to prescribe naloxone to prescribe it not only to a person at risk of overdose, but also to family members, friends, or other persons in a position to assist with such a person. The prescription can come in the form of a standing order. The law also states that a pharmacist is permitted to dispense naloxone under any prescription that is authorized under the law. So, if I'm a mom and I know my kid is a heroin user, I can go to my doctor. I think now somebody sent me an article after the last time saying that Walgreens and CVS have jumped on board in Texas with it too, that you can go to the pharmacy or to your doctor and ask for a prescription of naloxone for you to just carry around in case, a family member were to go into an overdose. It permits any person or organization acting under a standing order to store and distribute naloxone as long as they don't seek or receive compensation for those actions. So that's us. If we wanted to, we can have that in our facility. We can't sell it to people. If we decide somebody's a high risk, it would be basically just giving that to them as they leave. And we can also distribute it at the facility if somebody were to go into overdose and we wouldn't be held, liable for legal issues. It permits any person to possess naloxone even if they don't have a prescription for it. And it permits emergency services personnel to administer naloxone to any person who appears to be suffering an opioid-related overdose. So it's pretty easily accessible right now. And before 2015, it was none of these things were on there. So I think the only people that could administer it were doctors at hospitals. Yeah. This allows them to do it now. I don't know if they were carrying it on them. So, yeah. This is good, but at the same time, it's, I like that we're teaching it to the clients because I have never, can count on my hands for the past year that I've been doing overdose awareness with them of people who have heard of this. The clients don't know this information, and that's scary because they're the ones that are using and the ones that could benefit the most from it. All right, so there's 3 different forms of naloxone that is sold. The nasal spray, I'm from the research I did, this looks like the one that's used most when it comes to like the EMTs. What I'm being told is that the medication itself is $75 to $100. I believe everything's sold in tubes because you can administer twice. But the little stopper, I don't know how to explain it. It's like a little injector and it has a stopper that goes on the top that would easily fit inside of your nose. And then you push the spray up. I think the stopper you have to purchase on your own separately. So the cost of this goes up a little higher.
How does that work if you're not breathing?
You don't have to breathe in. Yeah, I went to a training and I was like, what? How are they going to suck at it? It just goes straight into the brain. Yep. Yeah. The injection is about $60, which, I mean, if we're talking about the clients, I would say this is the most affordable one. You would need a needle, like a horse tranquilizer needle, kind of. You know, you could go to a feed store. I think they sell them pretty cheap. You need a big needle. I don't know what that is, but maybe. Okay, so this is, yes, you are delivering this in the muscle, not in the veins. So you've got to get into the muscle to deliver the shot, which means that the little needles that people use to inject heroin are not going to work. If that is all you have at the time, then I guess you're going to have to really jam that in there. One thing I heard, which really scared me, and I was like, that's so terrifying, but at the end of the day, you're saving somebody's life. They said the muscle on the tongue can, only if you have a small needle, and you can't hit it in the muscle on your thigh to inject it in the tongue, because it's a smaller, I was going to say, if you're injecting it, they're unconscious, so they're not going to know till they wake up. Yeah, so it'd be more terrifying for the person delivering the shot. And then the auto injector, which I brought if anybody wants to see. And this is completely crazy to me. So I tried to do research on it. This costs up to $4,000 for a set of 2. This is it. So I don't know why anybody would recommend this one to anybody other than that it's so easy to use, and it feeds you the directions on how to use it, and you can't miss the muscle, you know. So I'm going to play it real quick and let y'all listen to what it says. Yeah, so it's pretty cool, you know, if you want to spend $4,000 on 2. They're useless after, am I putting it in the wrong way? So this is, and like I said, I don't understand this one because I did a lot of research on it. Have y'all heard of that website, GoodRx? So if you type in a medication, it provides coupons and it'll give you a list of all the pharmacies near your area and how much the medication would be so you can find the cheapest one. So I typed this one into the Dallas area and all of them were popping up at $3,800 for 2. You know, it's a carton, so it comes with 2 of these, which you can only use this one time. After the first time, the medication is gone.
How big is the needle though?
I don't know. I don't have a needle in here. But I'm assuming the needle's going to be probably the length of this, you know. So, but then I looked at the website of the maker of this medication, and they're quoting stuff at like $750. So I don't know where they're getting that from. I know that you can use insurance to cover these. United Healthcare was on there, Medicaid, Medicare. Everybody is on there. Now, how much they're going to cover, I'm not sure. You know, and if they cover the other ones, I don't know why they wouldn't just do that one instead of this one. So there are options. There's grants and stuff that you can apply for if you want to get this one. But again, like I said, I don't know why this one would be better than the other ones. You know, and the other ones are a little bit more affordable. Well, and I think of people who, you know, like my grandmother. You know, if she had to administer that, I'd probably want her to have this little guy.
Even if you're in, I can go and get you. You think
Yeah.
you're it'd be hard to do anything different.
Exactly. Well, shooting yourself in the leg with a needle would probably be easy, but I don't know. I would think this would be more for the people who are scared. This is easier. You're not going to stab yourself with it. You know, it's not going to. guess there's some other things, but this is the green states are everybody who has these laws set in place. They all pass that Senate bill. The blue states, I guess is that color, have yet to jump on board. So they don't have access to naloxone like we just talked about. Huh? How do I don't know how to use this? Wyoming, Kansas.
Oh, wait. Oh, Kansas. Yeah.
Okay, so briefly, we're going to talk about stimulant overdose. What do y'all know what stimulants are? Okay.
Like, maybe you see it in movies or something, like if somebody's overdosing and they put them in the shower. Is water supposed to wake them up?
No, it just cleans them.
Like,
Yeah. Drinking a cup of coffee is not going to help you. Taking a shower, milk shots, making somebody walk around or dragging them through the floor. None of that's going to wake them up. Yeah. So stimulant overdose, from what I've gathered, this is called overamping. There is a difference between overdosing and overamping because technically this doesn't necessarily require medical care. We'll go over which ones do and don't. So this could look like fast pulse or no pulse, short of breath, body is hot and sweaty or hot and dry, confusion, hallucinations, unconsciousness, clenched jaw, shaky, chest pain, seizures, vomiting, cannot walk or talk. So two different things that stimulant overdose could fall in, either mental distress or physical distress. Mental distress is associated with sleep deprivation, crashing, anxiety, paranoia. If a person is conscious and you are sure this is not medical in nature, they may just need support and rest. So that's the one that, and I feel like a lot of times we get mental distress stimulant overamping, I guess, on the men's unit. You know, because there's nothing for them. If somebody just used methamphetamine, amphetamines, cocaine, and then came in, we see the hallucination, the agitation, the sweatiness, the inability to sleep. Physical distress, jerking or rigid limbs, rapidly escalating body temperature and pulse, in and out of consciousness, severe headache, sweating, agitation, or chest pains. And an example, I think of ecstasy. Y'all heard of that? One of the things that it can do is cause your body to overheat. And if you get to a point where you're dehydrated so much and you're hot and your body is not able to regulate itself, you could go into medical distress. You know, so they would need immediate medical help. All right, so mental distress. If somebody comes in agitated, hallucinating, freaking out, maybe just took some PCP, maybe snorted some lines of cocaine, how can you help them? Yes.
Somewhere where to say, yeah, I guess like in like they can feel like there's things, you know, like go down, you know, just
Okay. It is basic stuff, yes. Give them a towel with water on it. Let them lay down. Give them water. Take them to a cool place. I know on the men's unit it's a little chaotic, so if somebody was mentally distressing, I'm going to remove them from that unit, maybe put them somewhere else where it's quiet. Physical distress is you're going to call 911, stay with the person. If their heart has stopped, do hands-only CPR and let medical professionals know as soon as you can what's going on. So risk factors for overdose, loss of tolerance. When are people most likely to lose their tolerance? What puts them at the highest risk? treatment, jail, any forced period of abstinence, mixing drugs, mixing opioids with other drugs, especially depressants such as benzos or alcohol. Why do y'all think that's dangerous? What else happens? Say you've been drinking or taking Xanax all day.
It makes it more powerful.
Yes, it can add to the power. I know with Xanax, you tend to forget things. I know with alcohol, you tend to forget things. So by the time you get around to heroin, well, how many Xanax pills did I take? Does it matter? I'm drunk or I'm high now. Another risk factor is using alone when there is nobody present. There's nobody to see signs of overdose. I don't know a lot of people who can really tell when they're overdosing. Especially with opiates, it's really hard to tell the difference between, before you know that it's an unsafe situation. Because a lot of the same symptoms apply to just getting high. Variation in strength of street drugs. This is based on the purity of the substance and the amount of the other ingredients used to cut the drug. So I always talk about that with the clients. Y'all are not the drug dealers. Y'all aren't sitting there with the drug dealers when they're mixing your drug together, so you can't honestly tell me you have knowledge of every single thing that they put in there. And then the last one is serious illness, AIDS, liver disease, diabetes, and heart disease. Serious illness, your immune system is already compromised, so you're already at a high risk. Your body's not able to fight off infection like a normal, healthy person would be able to.
Prevent overdose. Know your health status and your tolerance. Do not mix drugs and alcohol. If you do mix, choose to use drugs before alcohol. Be aware, using drugs while on prescribed medications can increase overdose risk. Don't use alone. Leave the door unlocked or tell someone to check on you. Do testers and check strength. Use less. Pace yourself. Talk to an experienced person or a trusted healthcare provider about reducing risk. Know CPR and get trained on giving naloxone. Choose a safer route than taking drugs.
Okay. So, this first question, will overdose prevention and naloxone training support continued or more use? What do y'all think?
Medication to counteract things that cause harm in your body, so you're going to stop doing that, whatever it is.
Okay. Yeah.
If you know, I can't because I'm going to take this medicine, I'm going to help you. You know what I mean?
Mm-hmm. Yes.
That's where I have a problem. Someone who does it at the same time, the ones that don't think like that,
That's been the argument.
Yeah, it's tough.
It increases awareness for them of what the consequences are, what might be going on. So some people will back off and use less or stop.
And the price of it will be even if you get it.
Try to be good in case you know what their proposition is.
Exactly. And that's how, anytime I present this to the clients, I always say that, because a lot of them sometimes struggle with this information too, because, I don't want them to think, okay, we think that you're going to go out and relapse and start using again, so when you do, here's what you need to do. I always make it clear to them that this is just a worst case scenario, but also think about your friends. I'll always ask them, y'all raise your hands if you have anybody that still uses. Never once has a hand not been raised. So you can ask them to apply this to their friends, family, or anybody else. Mm-hmm. Yeah.
So I know some pharmacies will give you even knowing what purpose you were using them for. And I always wonder about the food that they want you to safely disappoint.
Right. And the way I see it is, no matter how much we talk about it, bring them in, educate them, the clients are going to make their decisions at the end of the day, what they want to do with it. So having an option available, I mean, if the option is them use this versus dying, well, I'm going to pick this every time, even if they continue using heroin for the rest of their life. If they have something that's going to back them up, then I'm all for it.
It could be that one time that they go, okay, I'm done. At least they have an opportunity
Right.
to say I'm done and not be dead.
Right, use it, make them feel worse.
Right.
You know, how long will face? What's the amount of the
Is there, what do they do?
This wireless in the phone on that was not.
I mean, I would kind of categorize that from what I've kind of heard and seen with the stimulant overamping a little bit. The hallucinations, we've had some that are a little psychotic after, so there's nothing that can stop that from happening. You just kind of got to make them comfortable and.
I mean, like if you were to go to a hospital, they can give you something that will counteract the anxiety, right?
Well, yeah, if you go to a hospital, they can give you a lot of stuff that maybe would calm you down, but I don't know if our clients are doing that. All right, so what kind of message does it send to people in treatment? I've heard that, like I said, most of the time the clients are really receptive to this information, but there is always that one or two people in the group that feel like we're setting them up or we're not thinking that they're serious about quitting. Something that I always bring up with my guys when I go over this is the example of when I was in high school, there was huge debate over presenting sex education. It was long before nowadays. And I apply it to this because the argument was always, well, if we present sex education, we're basically telling our kids it's okay that you go out and have sex so long as you do it safely. So they decided that they were just not going to present it in my high school to avoid that. Well, what happened? Yeah. By my senior year of high school, we had a separate class for the pregnant ladies. So it's like, that worked really well. We can't stop people from doing stuff. All we can do is educate them. And it could be this one person, this one time, that decides that they're going to quit. Or they recall this information and they save somebody's life, their best friend who's overdosing. And that's the reality of it. The first time I did this group, I'll never forget it. A guy had to walk out because his friend overdosed on heroin and died the day before the group. So it hits home with all of them. 99% of people using know somebody who is overdosed. So this could be beneficial to anybody. It doesn't matter if you quit and you're sober 20 years down the road, it still impacts you. Okay, so I can't go back. Well, let me get off that. So this is the part that's a little controversial for some people. Harm reduction is what? What is harm reduction, y'all? Reduce harm. So reducing harm means in any form or fashion. Okay, reducing harm could be instead of using a needle to inject heroin, I'm going to snort it. You've reduced harm. All right. If I just, I'm going to drink alcohol instead of using heroin, reducing harm. I'm going to smoke marijuana for the rest of my life rather than smoke meth. We've reduced harm. We've made good progress. Okay. So this is focusing on, I think mainly just opiates, but it is basically, if I'm going to use, this is what I need to do to use in a good way. Okay. To put me at less risk. So I know a lot of people don't necessarily agree with these. This can be a trigger for some people. So it's kind of just coaching them through. I know.
I just think if you're using, you're not paying attention. I mean, who is gonna, when you're using, you don't think, okay, I'm just gonna do this one thing. I mean, maybe somebody else did.
Yeah. That's the whole point of this, though, is you weren't thinking about it before, and that's why we're talking about it. Because all of this, some of this stuff is pre-planned. Some of the stuff you talk about and you figure out before you ever start using.
Yeah, I don't think they understand, like, when our clients are entering treatment, most of them are presenting and the concentration stage will change. And what that means is they're taking a look at what's going on in their life and they're saying, I need to do something different. I'm not quite sure what that is. I heard the treatment's probably a good thing, so I'm gonna go check it out. So when we present them with things like that, because a lot of our clients that we hear, they don't end up staying clean, but it's important for them to have options and to like lessen the shame and the guilt if they do choose to go back to using. So again, they're coming in and saying, I need to do something different. I'm not sure what that is. And this could be that something different for them. I can stop, I'm here to stop using meth, but maybe I'm not ready to stop smoking marijuana. At least I'm here to stop smoking it. And maybe eventually that will turn into me not wanting to use it all, period.
And again, some of this stuff sounds ridiculous, all right, that we're going to go over. And some of it I know without a doubt the clients aren't going to utilize. But I've gotten a lot of good feedback from the guys later on saying, honestly, who sits down and talks to you about if you're going to use, here's how you need to do it to be safe. Nobody does that. That's not usually what's incorporated in we want you to get clean and stay abstinent for the rest of your life. So it meets them on a level where they're like, okay, this makes a little bit more sense. But we don't know that. And that's the thing is you don't know. So given this information, I'm not telling you to stop using. I'm telling you, fine, go ahead and use, but think about these things. Okay? Before you use the whole line of cocaine, maybe try a little bit to see what it does to you. That's what this is about.
And I think what's awesome, if I can say something, is when you talk about like 12-step groups, a lot of our clients are struggling with 12-step being so abstinence, and they're not ready to give up like everything. Like I have a client I'm working with who's like, I don't know if I'm ready to give up, alcohol and marijuana, but I think I'm done with the heroin roller coaster. And so, in looking at that, it's like if he gets upset and wants to go have a beer, and then that ends it, and great, I don't want that to be his only coping skill, but if that's his coping skill and keeps him from going out and shooting up, that's a win. So, and that's just it, because then he's not continuing to shoot up.
When I was in study, I was carrying all this stuff control. I wanted to have control of myself.
See, here's one.
So I didn't know how I did. I educated myself, and believe you, I was called nurse study at times and always took care of people because I knew how to reverse. And I knew what they were on, and I was reversing whatever they were eating. And I would educate them. I'd be like, you cannot drink THC with alcohol. You will die. You will get sick. I knew the effect. And people are out there, young kids, acting stupid. They're like, don't do it. No, your gut killer is going to take you. Right. So you can at least save somebody else. Or, right. It is important thing.
And you can think about this too from like a parent perspective. If this information was available for my mother, man, she would have probably saved a lot of years of struggle with all three of her kids had she had a little bit of assistance, or been able to know how to talk to her kids about stuff going on.
This whole thing set up to help somebody live one day long. And if they can do that, that's another day. And we might decide that we might decide not
All right, so we've got about 3 or 4 slides of prevention tips. We're going to go over these. And like I said, I think most of these are geared towards like opiate use, how to use it a little bit more safely, but it can apply to every other drug. Mixing drugs. If you're going to do that, use one drug at a time. Use less of each drug. Try to avoid mixing alcohol with heroin or pills. If drinking or taking pills with heroin, do the heroin first to better gauge how high you are. Alcohol impairs judgment, so you may not remember or care how much you've used. Have a friend with you who knows what drugs you've taken and can respond in case of emergency. Okay?
Yeah.
But that can apply even if your friend, even if a client's friend is getting high with them. Y'all both may not overdose. So if one of y'all is able to give the information, then that's good. Tolerance. Use less after any period of abstinence or decreased use. Go slow if you haven't used recently. Use less when you are sick. Do a test or shot or go slow to gauge how the shot is hitting you. Use less risky methods and be aware of new environment and new people. This can change how you experience the effects of drugs. And that's, again, something that I focus on with the clients. You'd be surprised how much your environment can impact how a drug affects you. So we talked about that earlier with the mental distress. If you put yourself in a calmer location, it's going to impact how you're able to kind of stabilize. Quality. Test the strength of drug before you do the whole amount. Try to buy from the same dealer. Talk to others who have the same dealer, which the clients have informed me that that's ridiculous and, don't do that. Know which pills you're taking and try to learn about variations in similar pills, and be careful when switching from one type of opioid pill to another since the strength and dosage will vary. When using don't use alone, use with a friend, develop an overdose plan with your friends or partners, leave the door unlocked, or call or text someone you trust to have them check on you. So again, I'm being told that to leave the door unlocked is ridiculous, okay? So I'm thinking maybe if you live in a house with other people to leave your bedroom door unlocked. Most people say they don't trust leaving their apartment doors unlocked, for anybody to walk in. Especially if you're paranoid. Right.
The windows with the door unlocked.
One of the things, and at first the clients were like, develop an overdose plan with your friends. I love that, okay? And the clients at first were like, that's so stupid. But after I talked to them about it, they were like, actually, that's kind of genius. Talking about it while you're sober, not high, about what you're going to do in case of an overdose, I think would actually save somebody's life. And like Adrienne was saying, people aren't thinking about, oh, that education class, what did I learn? How can I save this person? They're not running through that. They're probably in a frantic mode. All right. So if you have something already set in place, it's going to help the process go a lot smoother. And that plan could be, I'm going to put you in the recovery position and I'm going to head on out. If that's the case, then that's the plan. But you know already that I'm not going to leave my friend lying on the ground, choking on his vomit, and head out of there. I know I need to call 911, put him on his side, and then I can leave. So I stress that to them. Talk about what you would do in this case. Get with your drug-using friend and say, listen, what if one of us overdosed? What would you feel comfortable doing, realistically? Because the feedback I get is most clients have not or don't see themselves sticking around for the police to arrive or the EMTs. So again, that's why this is important too, is kind of talking about what your other options are so that that person has a better chance of living, even if you don't stay. Age and physical health, stay hydrated, drink plenty of water, eat regularly, get enough sleep, and rest when you feel worn down. Carry your inhaler if you have asthma. Try to find a good non-judgmental doctor and get checked out for any health factors that may increase your risk of overdose. Mode of administration, be mindful that injecting and smoking can lead to increased risk. Consider snorting, especially in cases when you're using alone or may have decreased tolerance. Be careful when changing modes of administration since you may not be able to handle the same amounts. And then, obviously, what's the safest route of administration? None.
I feel like that was
Right.
Yeah.
Next safest route? Swallowing. Okay. Next one? Snorting, smoking, and inserting. Clients think that's hilarious. Okay. There are people out there that do that.
Yep.
And then naturally last would be injecting. Okay. So again, even something as basic as this, okay, if you're going to continue using heroin, why don't you try snorting it? Why don't you try, any of those things could help decrease their risk. I know. I know. Okay, tips for calling 911. We already talked about this a little bit earlier. When you call 911, you want to stick with just the facts on the phone. My friend's unconscious. His lips are blue. He's not breathing. He didn't wake up when I performed the sternal rub. Whatever it is that you were seeing, that's what you need to be telling them. Don't say stuff like he's overdosing. He just used some heroin. He's a drug user. He overdosed 2 weeks ago. They don't need to know any of that information. All they need to know is this is a high priority because we don't know what's going on with this person and we need to get there immediately.
Because that would make them drive slow or,
Everybody has their own opinions about these things. I've heard people say if somebody's overdosing and they don't care about their lives, let them die.
It's not drugs, that's what we want to dispatch police also.
Exactly.
And
Exactly.
the paramedics probably get a call of someone that they consider invalid or accident. They might respond to that first.
Yeah. So when calling, it says keep the noises to a minimum. If you're in like a club, the cops are going to come. Okay. If you're in a location where there's people screaming in the background, the cops are going to come. Like you've got to think about if it sounds like a high risk, there's no doubt in your mind that they will show up. Okay. If you do call the cops, it's always a good idea to remove drugs and paraphernalia from site. If they do come in, we want to avoid you being held liable. So I always stress to the clients, don't pick up needles, don't touch used equipment of any sort, just kind of put it maybe in a bag, Walmart bag, hide it in a cabinet somewhere out of sight. I know, but the number one reason why people don't call the cops is why. They're afraid they're going to get into legal trouble. So if we can avoid some of those blatant, right in your face, yes, you're going to get in trouble for that. So, take care of that. And then when the paramedics arrive, that's when you want to tell them exactly what happened, that your friend is a drug user, tell them what drugs they've used. If you do decide to stick around, if somebody decides they want to leave, maybe they can write it on a piece of paper and put it on their friend's chest. I don't know. That could be a part of the plan.
Sticky note on the forehead.
Yes. So again, these tips are just to kind of minimize the chances of the police showing up along with the paramedics. But 9 times out of 10, anytime you see something called, I usually see a firefighter truck, I see the paramedics, and I see the police. I think it depends on the situation, how busy they are, who's going to show up. So I would just always plan for the cops to be there. But if they hear that it's a high-risk situation, they may bring more reinforcements, and they may be a little more strict with what they deliver. Have y'all heard of the Good Samaritan law? What is that?
Liable for trying to help somebody.
Exactly. So the light blue states have not adopted this. So naturally, Texas falls in that. We don't have the Good Samaritan law when it comes to drug overdose. So again, this furthers the likelihood that people are going to leave the scene rather than stick around because they don't want to get in trouble too. So this was shot down when they presented it with the Senate Bill 1462. It was shot down, but I'm sure they're going to continue trying until, most of the states have jumped on board. So I think we'll get there eventually. Yeah. Well, and this is what, again, I present all of this to the clients. So we do talk about if your friend overdosed, what would you do? Run it through with me. Because, like I said, 9 times out of 10, they're not going to stick around. Sometimes if somebody wants to get on the floor and do the recovery position, they'll show everybody. We'll talk about some safe steps to take, about the post-it note or the writing, but really, when the EMT arrives, if they have the information of what this person took, man, that could go a long ways in them knowing what to do to treat the person. So while it may seem ridiculous, that may be another plan before you get high, let's write down what we're doing. So in case of emergency, it's already there. You don't even have to think about it.